Good morning, everyone. Thank you so much for joining us today at the University of Richmond Law Review Volume 56 Symposium. My name is Ren Warden, and over the past year, I've had the honor and the pleasure of being the Richmond Law Review Symposium editor. Before we jump into our program for today, I'd like to say a few words. First, about the purpose of the symposium, and second, just a few housekeeping matters. As you know, the symposium is titled Forming a More Perfect Union with Public Health Law. The coronavirus pandemic has raised sirens around long extant health inequities, inefficiencies in regulatory agencies, and public distrust surrounding local health governance. It has forced us to face urgent questions about the way we legislate, regulate, and adjudicate health in this country. The purpose of this symposium is to try to address some of those concerns. Over the whirlwind of the past 2 years of the coronavirus pandemic, we have witnessed rapidly evolving scientific endeavors, legal rules, and social norms. Our lives have turned upside down in such a short period of time. Virtual meetings, depositions, hearings, trials, and classes were the necessary default. We've seen new vaccines and the emergency authorization of those vaccines. We've seen even more incredible health disparities based on social determinants like race, class, and gender. Our union is far less than perfect, but there are tangible steps that we can take to get to our more perfect union. So today we are going to be exploring some fascinating and pressing ins and outs of where we've been, where we are, and where we're going. We have some incredible presenters here today from Washington, D.C., Texas, Virginia, Georgia, Maryland, Pennsylvania, and Colorado. We have public health researchers, local health governance experts, a medical doctor, a philosopher, a boatload of law professors, and one very impressive third-year law student. These presenters have been published in JAMA, The Lancet, New England Journal of Medicine, the Yale Law Journal, Columbia Law Review, and countless others, not to mention their extensive bibliography of books. That's all to say that we're in great hands for our guests today to guide us to answers, or at least towards a framework to address these pressing health law issues, to eventually help us form that more perfect union. So next, just a couple of housekeeping things. For those seeking CLE credit, there's no need to worry about checking in for attendance. At the end of the symposium, we will export an Excel spreadsheet attendance log based on data that Zoom creates when you log in and out of the online event. So that will be done automatically at the end of the event. You'll receive an email from Mary Ruth Keys next week with the CLE attendance form and a brief feedback survey. If you have any questions or comments for our presenters, we encourage you to share those in the Zoom Q&A box at the bottom of your screen. At the end of each session, we will have a brief question and answer period so that the presenters can respond to you. So we will jump right into our first event. Yael Cannon will be presenting the keynote presentation on health justice, the role of law in advancing health equity. A little bit about Yael. She is a keynote speaker at, she's an associate professor at Georgetown University Law Center and the director of the Health Justice Alliance Law Clinic, which brings law students, medical students, and health professionals together to remove legal barriers to health in a range of areas in poverty law. At the Health Justice Alliance Law Clinic, students advocate holistically to secure housing, education, public benefits, and family stability for low-income families in Washington, D.C. Professor Cannon is the past chair of the American Association of Law Schools Poverty Law Section. She previously taught at the University of New Mexico School of Law, in the Medical Legal Alliance, and at American University Washington College of Law, where she served as acting director of the Disability Rights Law Clinic. Prior to teaching, she practiced law at the Children's Law Center in Washington, D.C., through a medical legal partnership with Children's National Medical Center. Her research focuses on the ways in which the law can protect the social and economic rights of children and families living in poverty to ensure their health and well-being and promote health equity. She's a co-author of the textbook Special Education Advocacy, the treatise AIDS in the Law, and articles in law journals and other periodicals. Professor Cannon graduated with distinction from Stanford Law School and summa cum laude from the University of Maryland with BA degrees in history and African American studies. Yael, thank you for being here. Please take it away.
Thank you so much, Ren. It is such an honor to be here today and with such a superstar lineup to discuss this really, really important topic. Before I dive in, I would like to thank the Richmond Law Review for their work on this incredible symposium today's discussions, as well as the journal issue that's going to be coming out. And a special thank you to Symposium editor Ren Warden, who has just done a fantastic job and has been such a pleasure to work with. It's really an honor to be able to talk with all of you this morning about the concept of health justice. So let's dive in. Today, we're going to talk about the role of law as a determinant of health and health equity, and the role that lawyers can play in health justice. And I'm actually going to begin with a story about the Brent family. And Brent is a pseudonym that we're going to use to preserve attorney-client confidentiality. So a few years ago, the Brent family walked into a free health clinic run by Georgetown medical students and faculty at a DC homeless shelter. They had been evicted from their apartment, and the family of 5 had been homeless for 2 years. That health clinic that they walked into has a medical legal partnership with our Georgetown Law Clinic. So what that means is that we, the lawyers and law students, have trained the doctors and medical students to screen for health-harming legal needs, and we're going to talk more about that concept today, and refer cases to our legal team. So along with their doctor's appointment, when the Brent family came into this free health clinic, they also got a legal checkup at the doctor's office, which identified that the family was actually in need of legal help to overcome housing discrimination so that they could get out of shelter. So the doctors referred the family to our law clinic, and our clinic students fought the housing discrimination through a civil rights case and helped the family secure housing. And the family was doing great once they got out of shelter and got housed and got settled. And Mr. Brent was able to go back to work. Then came COVID-19, and their Washington, DC neighborhood was ravaged. Mr. Brent lost his job. The kids were hungry, and the Brents really couldn't make their rent. They feared being evicted yet again, becoming homeless yet again. And the parents let us know that they were skipping meals so that the kids could eat. And before I tell you what happened to the Brents, I want to set the scene in their neighborhood for you. So in Washington, DC and our surrounding region, we have tremendous health disparities across a number of measures, including life expectancy. And that's what you can see here more regionally around Washington, DC on this map. The Brent family lives in the bottom Southeast DC corner of Washington, DC in Ward 8, which is an area of DC that is very high poverty, that is over 90% African-American, and average life expectancy in the Brent's Southeast DC ward is at least 15 years shorter than for residents of the city's highest income, predominantly white ward, which is DC's Ward 3. So why is that the case? How is it possible that within one city you could have such a tremendous gap across different neighborhoods in life expectancy? So that is this concept that Ren mentioned earlier of social determinants of health. It's the idea that where we live, where we work, where we eat, play, age, where we go to school has a huge impact on our health. Actually, as much as 80% of our health is driven not by the care we get when we go to the doctor's office or by our biology, but by social conditions, which have become known as the social and also political determinants of health. So how does this play out in the Brent's neighborhood? So in DC's Ward 8, there are incredibly poor housing conditions in many of the homes. There is high unemployment. There is food insecurity, and the neighborhood is known as a food desert. So there actually isn't even access to much fresh and healthy food. The neighborhood is also known as a medical desert. So there isn't robust healthcare. There is lower quality education, and many of the residents experience chronic stress. And all of these social conditions harm health. So when COVID hit, we learned as the pandemic unfolded that Ward 8 has only 11% of Washington, DC's residents, but has had more than 20% of the city's COVID deaths. And these same social and political determinants of health contribute. So Ward 8 has more essential workers who had no choice during the pandemic but to go to work and couldn't stay home like many of us and work from home on a computer. Many families in that neighborhood rely on public transportation to get to school, to get to work. So had no choice, but at the height of the pandemic, but to be, on buses, and the bus lines actually in DC were cut pretty dramatically during COVID. So when they were running, they were quite crowded. And because there's no grocery store nearby, anytime they want to get food, they have to take a bus, sort of multiple stops just to get to a grocery store. It's also more difficult to socially distance in neighborhoods in Ward 8 that are high density and where many families are living sort of overcrowded, sometimes multiple families in an apartment. And it's important to note that COVID deaths and these other poor health outcomes that we have seen, since long before the pandemic, that disparities around them persist across socioeconomic status in Washington, D.C. And this is the case across the country too for people of color. So what does that mean? That means that these inequities are not just a function of poverty, but also of structural racism, which is really important to me. And many families like the Brents are faced with a compounding burden, facing people of color who are also living in poverty. And I wanted to note that this is the story in Richmond too. So within Richmond City, life expectancy varies by 20 years across census tracts, which is a pretty remarkable gap. And that data comes from a report from the VCU Center on Society and Health called Health Equity in Richmond. And we're actually going to post that into the CLE materials as well, so people can access that report if you're interested and read more, because the health inequities in Richmond, Virginia really span way beyond life expectancy to a number of different measures. And there are very interesting discussions in that report about the social determinants of health that drive them. And these health inequities in both of our cities and across the country really are a grave injustice. They are avoidable and preventable, and they are driven by social conditions in which law and policy have played a role. So this tells us that health justice, it's racial justice, it's economic justice, it's social justice, it's environmental justice. And COVID has shined a spotlight on these long-standing disparities. I think Ren used an interesting term, sort of the siren calls, and the role of social determinants of health as well. And COVID has also exacerbated them for some people. And really what that tells us is that injustice itself is an underlying condition. So that's all very bleak. But there is good news, and we are going to talk about that today. So just as law and policy have had an impact in negatively harming health and health equity, law and policy can actually do something about it, and lawyers can do something about it. And that is the pursuit of health justice. So I want to take a quick minute to just try to do something interactive, and so bear with us if hopefully the technology will cooperate. So I want everyone to find the little Zoom Q&A button that should be, I think, at the bottom of your screen. And I'd like you to give some thought to what types of legal issues and areas of law can affect the health and well-being of low-income patients. And if you could just, type a word or two about some of the types of legal issues or areas of law that affect health of people who are low income. Let's see some ideas that we might generate. I'm going to stop sharing for a second so we can see what's coming through on the Q&A. Okay. So I see employment discrimination, disability benefits, access to medicine, discrimination, eviction and housing, racial discrimination, bankruptcy, family law stress, environmental issues like zoning laws, unfamiliarity with legal employment protections, water shutoff, Great. Life planning. Yeah, and end of life planning and areas of law related to that. Wonderful. Okay. So you touched on many of the areas of law that impact health, and there really are so many. And I'm going to go back to sharing my screen now, and let's talk a little bit more about some of these areas. Okay, so okay, health justice really begins with an understanding and an identification of law's impact on health and health equity. And many of the areas of law that you mentioned today are captured in this graphic from the Medical Legal Partnership in Boston. And they're also captured in this graphic about the 5 major domains of social determinants of health that have been identified by the US Department of Health and Human Services in a project that they have called Healthy People 2030, which sets national objectives for where we want to be with health and well-being as a country by the year 2030. And HHS has recognized that these 5 major domains of social determinants of health have a huge impact on our health and health equity. And you can see how the areas of law that all of you put into the Q&A, which is fantastic, are implicated in these different domains. And so here are a few examples, some of which, we saw in the Q&A. So the sort of neighborhood and built environment, so someone mentioned evictions, even actually the threat of evictions has been shown to impact health and mental health, just as evictions themselves, when they're actually carried through, certainly do, and have been well documented to sort of cause what's known as downward moves, where people either move, end up in homelessness, like happened with the Brent family, or end up in overcrowded or substandard living conditions, which also affect health. Other housing law issues like discrimination, housing discrimination was mentioned in the chat, access to housing assistance, reasonable accommodations in housing. Someone mentioned water shut off and utilities. All of those are legal issues under neighborhood and built environment that impact health. Economic stability is a major predictor of health. So legal issues related to employment, we saw some of that in the chat. Consumer law and debt issues, as I was coming back to the screen, someone mentioned medical debt, and really all areas of debt and bankruptcy can impact health. Public benefits law issues, immigration status, which is closely connected to pathways to employment. All of these different issues affect economic security. They also affect food security, which is closely tied to health. And I'll just talk about one more, education, access, and quality. So education is a major social determinant of health. It's actually been written about as the neglected social determinant of health because it's not always talked about as much. But whether a person graduates high school is one of the single greatest predictors of lifelong health. And there are a lot of areas of law and legal issues that affect that. So special education law, that ensures people with disabilities have access to services and can achieve independence. Legal issues around preventing entry into the school to prison pipeline, educational access and supports under federal law for kids whose families are experiencing homelessness. All of these areas of law, affect health and can kind of be seen within these domains. And I wanted to note that in 2006, the American Bar Association issued a report that really has a lot of resonance today, where they issued a call for greater access to lawyers in areas of civil legal need that affect all of the issues we see in this graphic. In fact, the ABA called for a right to counsel in these types of civil cases that are so fundamental to human need. And in the article that I've written that is coming out in the Richmond Law Review Symposium issue, I actually map these areas of fundamental legal need that the American Bar Association identified onto these 5 domains of social determinants of health. And we can see how all of the areas in which many Americans have civil legal needs that go unaddressed, for which they don't have access to counsel, really impact health. A major example of this is evictions, which we've been talking about. So Jim Sandman, who is the former president of the Legal Services Corporation, has noted, if you go into any metropolitan courthouse or state house, what you're going to see is that more than 90% of tenants are facing eviction without a lawyer, while 90% of landlords are represented by counsel. And because of concerns of those injustices, and I would argue those injustices are also health injustices, a number of states and cities have actually been trying to really move to expand access to counsel around evictions. And actually 3 states and more than a dozen cities in just the past few years have passed a civil right to counsel in eviction cases, and many more have introduced major initiatives to expand access to justice in this area. It's also been a priority of the White House and the Attorney General's office since the expiration of the CDC's moratorium on evictions last year, and sort of the anticipated tsunami of evictions that everybody is concerned about now that the sort of federal emergency rental relief that was sent out to states has largely run out. And if this happens, this eviction crisis that we are starting to see unfolding will be a public health crisis on top of an existing public health crisis. So it's really an issue of health justice. So what does health justice require of us? How can lawyers be part of the solution? Health justice really is the leveraging of law and policy to eliminate health disparities. And I wanted to note that it's intentional that the word justice is part of the framework, because it requires us to acknowledge that law and policy have caused many of these disparities. And it also requires us to examine the role that law can play and must play in remedying these problems. So we, the lawyers, we can make a difference in enforcing the law and shaping law and policy to advance health equity. So how? What does that look like? Well, with the Brents, the Health Justice Alliance team, helped appeal Mr. Brent's denial that he received of unemployment benefits, which was really important to the family's economic and food security, advocated for higher food stamp rates due to the decrease in income that they experienced when Mr. Brent lost his job, negotiated a rent reduction, protected the family's rights under our city's eviction moratorium, and once that was lifted, helped secure emergency rental relief to prevent the family's eviction. So now the family is no longer hungry, which is really, really important. The parents are eating along with the kids. They avoided eviction. And we really helped the family ensure that laws are working in a way to promote their health, that law is a determinant of good health. And we can think about the role of lawyers on different levels. So the enforcement of extant laws, those laws on the books like the team did for the Brents, but also our role in structural change, the law, policies, and systems reform that is really needed to get more upstream and to prevent these issues in the first place. So let's finish up by delving deeper into the health justice framework and unpacking what it requires of us as lawyers, and we're going to discuss that through the lens of another story. So a few years ago, another family, we'll call the Coopers, walked onto a mobile pediatric van for a checkup, and you can see it pictured here. And that might sound strange, onto a van for a checkup. So the Georgetown Community Pediatrics Department uses these very low barrier access to healthcare models. So they have a pediatric mobile van that is a full doctor's office on wheels. It parks in low-income neighborhoods in DC that have historically been medical deserts for primary care. And kids can just walk out their front door and right onto the van for a checkup. The department also operates school health centers at 2 underserved high schools in Washington, DC, and you can see part of the team outside one of those high schools in the bottom picture. And so when families and teens walk into these health clinics, they get a legal checkup. And this is really the MLP model, the medical legal partnership model, this idea of embedding lawyers into healthcare teams to identify and address legal barriers to health. So the medical legal partnership movement began in the 90s and has really grown tremendously It was an idea born of frustration when doctors at Boston Medical Center realized that kids were cycling in and out of the emergency room with really serious asthma attacks. And despite receiving like the best treatment possible, many of the kids kept having asthma attacks and kept coming back to the ER. And so the doctors talked with the parents about the conditions in their homes and learned that many of those kids were living in substandard housing conditions that are actually known to affect and exacerbate asthma. So rodents, pests, mold, dust, and the parents were not being successful in getting their landlords to actually improve the housing conditions. And the doctors were frustrated. They realized they actually didn't have the tools in their toolbox to get these kids healthy. They needed a lawyer to advocate for improved housing conditions. So they had this idea. They brought a lawyer from Boston Legal Aid onto the healthcare team. They gave her a pager, and just like they could page a cardiologist to the emergency room, they could page the lawyer as well. And the lead doctor there, Dr. Barry Zuckerman, wrote a really powerful article in the Journal of the American Association of Pediatrics that I recommend to you, and actually we can also put it in the CLE materials, called Why Pediatricians Need Lawyers to Keep Children Healthy. And since that time, the value of medical legal partnership has been recognized by a number of leading national organizations, really with a recognition that it provides low barrier access to justice. People can access lawyers right out of their doctor's office, right in their neighborhoods. It allows us as lawyers to bring our services to the community, ideally preventively, before legal issues, whenever possible, become crises, because healthcare professionals have been trained to really look for unmet legal need, before the time that a family might even recognize that they have a legal issue that would require a lawyer. And it allows us to see problems that are neither purely legal nor purely health related as both. It's really a silo busting model. And I think a lot of health justice is about breaking down silos and allowing for collaboration in pursuit of health equity. Okay, so back to the Coopers. So when the Coopers walked onto the Georgetown pediatric mobile van for help as part of their health checkup, the youngest child, Mia, was tested for lead exposure. And it turned out that she had very high levels of lead in her blood, and she had been lead poisoned. And in addition to that health checkup, the family also got a legal checkup, which helped the providers understand some more things about the conditions that led to her lead poisoning and what was happening as a result. So they realized that the family was living in an apartment with a number of horrible housing conditions, including lead in paint and in the water. And many of you have read about the impact of lead poisoning on children, with sort of national news coming out of the water crisis in Flint, Michigan. But lead exposure can cause significant and lifelong developmental delays when it impacts children. And we have seen during the pandemic that the effects of poor housing conditions on health have been a big problem, because you can imagine that when people are stuck at home, like many children and families have been, for much of the day, for much of the last 2 years, that if you are living in substandard housing conditions, those conditions are going to have an even compounding and greater impact on health if you're at home living in those conditions kind of many more hours of the day. So when, Mia's family got this legal checkup, it also revealed that Mia was having challenges in school, which is not surprising given the developmental impacts from the lead exposure, and that her mother was having difficulty securing the necessary educational services and accommodations to help her because she was struggling in school. The legal checkup also revealed that Mia's Medicaid had been terminated, which was making it much harder for her to get the treatment that she needed. So health justice really begins with identifying where the law is impacting health. And The students who were working with Mia's family, analyzed the impact that law was having as a social determinant of health on her and her family, and really worked holistically to see how these different laws and systems were interconnected and how these legal needs that they identified really were health harming legal needs. And an important sort of first step in health justice is making these connections. But then we have to dig deeper and understand the why. So once we've identified the law's impact on health, health justice really requires us to understand the why behind the Cooper family's story. So sort of the role of structural racism in redlining, in restrictive covenants, in zoning policies and laws that promote gentrification, and laws and policies that have really segregated and continue to segregate Black families and other families of color into neighborhoods with really poor housing stock. And that's a story we've seen in our city and in Washington, D.C., and so many places across the country. And then you couple that history of law and policy with a lack of robust prevention and enforcement mechanisms to ensure that housing is lead-free, to ensure that it is safe and healthy in other ways, and you can see the why. So our students explored these issues. We talk about them a lot in the classroom and sort of across disciplines with our med students and our physician partners. And they also work to understand how the educational system often misses developmental delays like Mia was experiencing and funnels children of color into the school to prison pipeline, which we know has an impact on health, given what we talked about with the importance of educational achievement of high school graduation as sort of powerful predictors of lifelong health. When kids are excluded from school, that's problematic on many levels, including the impact on their health. So lawyers can represent clients impacted by these disparities and sort of enforce the laws we have on the books to ensure better health. And here's some of our students outside of the courthouse in Washington, D.C. For the Coopers, what happened was that the medical and law students teamed up. They talked to the parent about her concerns and her goals, really making sure that she was, at the center, driving whatever action our team was going to take. And in pursuit of her goals, they advocated in our housing conditions court to get the lead remediated. And in that advocacy, the medical students were really key to demonstrating to the court and our physician partners the impact of lead on the child's health and development and sort of the urgency of the remediation. The students also flagged that the District of Columbia Housing Authority had actually inspected this unit prior to the family moving in, which is required when a family is using a housing voucher to move in to a rental unit in DC, and that they had passed the unit for inspection. And so the students worked to sort of hold the DC Housing Authority accountable to make sure that they paid for the family to actually stay elsewhere while the repairs were being made, because that actually is a really dangerous time for a family to be in a home when lead repairs are being made, because there can be a lot of dust and children can have lead exposure just during the repair period. The team also worked to restore the child's Medicaid, which was really, really important, so she could start accessing the treatment she needed around her lead exposure. And they also obtained comprehensive educational and developmental evaluations and advocated for robust special education services to help Mia really thrive in school, which was a really important part of our legal case as well. But we talked about the importance of sort of getting upstream. And, beyond this enforcement of laws on the books, health justice really requires the reform of law and policies that harm the health of marginalized communities and drive health inequities. And there is, wonderful health justice, legal scholarship, sort of exploring lots of opportunities for systemic change to further health equity in our country through law reform. And you can explore the work of Rakaya Yerby and Lindsay Wiley and Seema Mohapatra and Emily Benver and others who are writing in this space, as well as my work and some of the discussions that are going to come out in the symposium issue to sort of envision what that change might look like. And certainly COVID gave us a lot to think about in terms of how we might sort of dream and envision a very different system when the pandemic sort of highlighted so many disparities. And for those of us directly representing clients around areas of legal need that harm health, we can really use what I call a clients to policy approach, which is sort of a nod to a number of sort of lawyering models that have been proposed in the legal scholarship, such as political lawyering that has been proposed by Deborah Archer, and also in the medical legal partnership context, there's an idea of this patients to policy approach, the idea that doctors can see the problems facing their patients on the ground and think about how they can draw on that to be policy advocates, physician advocates for policy change. For us as lawyers, we can use a clients to policy approach. And what does that mean? So as we're representing clients, we can identify gaps, patterns, and problems with the law. So for example, the team representing Ms. Cooper, Mia's mother, came to recognize that lead laws in DC are actually more reactive than preventive. And they actually largely require interventions after a child has elevated blood levels and really has been lead poisoned already. And only when those levels reach, such high heights as to actually trigger intervention by any government agency, which in DC, the law was written in a way that those levels were well beyond what the CDC and the EPA have as their guidelines for, when lead exposure should trigger government intervention. The other thing that we realized is that the inspections in our city don't actually prevent lead exposure because they only require a visual inspection for peeling paint. So when those DC Housing Authority inspectors walked through the unit, they were only supposed to just kind of look around and see if any paint was peeling. But the standard, the best practice for lead inspections is really a swipe test. And that's a test that would find lead dust that isn't detectable to the eye, which is how many kids experience lead exposure that has come from lead in paint. So our legal advocacy, really gives us a window into how the law is not working on the ground in the lives of individuals, how it is impacting inequities. And our legal advocacy gives us an evidence base of client stories and data that can be really used to justify and support the need to invest in more equitable policies, laws, and systemic changes. And with our training as lawyers, it helps us to envision what an effective law would look like. What would it look like if we had laws that really promoted health for people who are marginalized by virtue of racism and poverty? What would it look like for a law to actually promote health equity? And our direct legal representation positions us well for policy advocacy that actually draws from those experiences. So here, the legal team and our medical partners testified before our DC legislator, the DC Council, in support of a bill that would really drastically strengthen lead prevention and enforcement laws in Washington, DC, and really put the city kind of on the map as a national leader in that realm. So for example, the law would require all landlords renting property built before 1978, which is the year in which lead paint was banned, nationally, to provide a clearance report showing that lead dust swiping was completed and that the property is safe. And in Washington, D.C., it's probably the case in Richmond too. We have many, many properties. Most properties were built before 1978. And so, if all of those properties would be tested proactively with a lead swipe test, we could prevent a lot of lead exposure. The law would also mandate repairs and provide funding for landlords to complete those repairs. And our students advocated for this bill by testifying about the problems with our current laws that they saw, through their casework and the ways in which the new law would fill those gaps. And happily, part of that legislation actually passed. And what's wonderful is now lead hazard levels have been modified in Washington, D.C. to bring blood thresholds in line with the CDC standards. So we can actually detect lead in blood much earlier in DC and trigger government intervention before that lead has accumulated in the blood to super high levels. And we continue to advocate for the remaining portions of the bill as well. And it's also important for lawyers and our collaborators in public health to engage affected individuals and community organizations. This is really important, and a number of organizations such as the American Association of Medical Colleges are paying a lot more attention to this idea of engagement with communities to really let communities drive the health justice agenda as opposed to it coming from lawyers and those in the public health and healthcare space. So in our situation, the students really wanted to partner with their client to support her in pursuing health justice and give her a leadership role if she wanted in that work. And she did. She wanted to make sure that other children in Washington, D.C. don't experience what her child did. She was committed to broader justice beyond just her family. So our students prepared her to testify and supported her as she walked into the DC Council building for the first time in her life to testify at a hearing. And they also took the time to connect her with other community organizations and grassroots coalitions working on this issue. And our students connected with those organizations to listen to them and hear what the broader concerns were. And I think through that experience, the students saw how important it is that we as professionals listen to the people and communities we serve, to learn from them about their needs and their goals and the change that they want to see. And so sometimes as lawyers, the best role for us is one in which we let individuals and communities who are affected by disparities lead on these issues. And we can really play a supporting role in helping to elevate their power and thinking about our lawyering tools as supportive to their leadership. So let's see. Okay. So health justice has a really big agenda. I covered a lot of ground today. I did a lot of dreaming about where we might go and where do we begin. And I actually think that we begin by training future leaders to advance health justice. It's the next generation of lawyers, so the law students who are here today, as well as the next generation of doctors, of nurses, of hospital administrators, of advocates for public health, of policymakers and policy advocates who can have a big impact by learning to practice differently in their own professions. And I think that gives us, as law professors, those of us who are in other academic and training institutions where we are training the next generation of public health leaders, including lawyers, a special responsibility to make sure our students have the knowledge they need, the knowledge about health inequities, about the role of law and policy and systems driven by structural racism, really in creating those underlying social determinants of health that we talked about today that drive disparities. And we can also equip our students with skills and values that they need to leverage law and policy to pursue equity. And and really give them the tools that they need to act to ensure health justice. And I think this agenda is more important than ever as we are perhaps emerging from the pandemic and have many lessons that we have learned that we can draw on today that I know are going to be discussed throughout the day. So I have put up here my name and email address. There will also be materials in the CLE folder that you can access, including these slides and some of the reports that I mentioned today. And some of this discussion is also going to be further fleshed out when you have a chance to read the awesome symposium issue that will be coming out from the Richmond Law Review. I'm really looking forward to the discussion throughout the day to touch on more of these topics. But I think for now, I'm going to stop sharing my screen and turn it over to Ren for any questions that we might want to talk about.
Great, so we have a few minutes for a Q&A session right now. I'll go ahead and ask one question. Could you tell us a little bit more about the medical legal partnership model? Can you talk about how doctors know how to spot legal issues, and do they get involved in the case after they refer a patient? What does that process look like?
Oh, such a good question, Ren. So yeah, so the medical legal partnership model looks different in different places. It focuses on different populations in different places. So you heard me talk a lot about children and families. That's our focus in our medical legal partnership. And I think it's an important focus because there's a lot of literature out there in the public health sphere about children and the fact that childhood, early childhood, adolescence, infancy are really, really important points in our life course where challenges with health can have compounding effects, throughout our lifetime. And so focus on children is an opportunity to kind of get upstream. But there are medical legal partnerships that focus on veterans, that focus on the elderly, that focus on LGBTQ populations, that focus on cancer patients. We have two new medical legal partnership programs that we are sort of building out right now. One focused on cancer patients, and the other focused on pregnant women and women who have just given birth, to sort of address huge maternal health disparities that we see in Washington, D.C. and around the country. But across these different medical legal partnership models, sort of some parts of the framework really remain consistent, and it starts with training doctors and healthcare professionals. So we actually put on trainings for the doctors that we work with about Medicaid law, about public benefits law, about housing law. So as the laws were kind of changing throughout the pandemic around some of this, that made that very hard because one minute we have a federal eviction moratorium and the next minute we don't. And one minute we have a DC eviction moratorium and the next minute we don't. But it was really important to keep our physician partners kind of up to speed as best we could on that legal landscape so that they were able to engage with their patients and spot legal issues. There's also kind of the use of screening tools, like the sort of legal checkup form that I showed in the presentation, that also gives doctors tools that they can really build in right into their practice, ideally in ways that don't add a lot of time. Since we know how now when we go to the doctor, it often feels so rushed. But to allow doctors to actually spot these issues and refer cases to families. And then your second question that was about how doctors can sort of collaborate on cases kind of maybe after the point of referral, that's a really important part of the model from my perspective. So medical legal partnership doesn't just give us a chance to reach people we might not be able to reach or reach people more upstream. It's also about changing the way our legal advocacy plays out. And I think that having doctors on our team allows us to have built-in medical experts, which is really important to a lot of these areas of poverty law that are social determinants of health that we talked about today. They can make us better lawyers by helping us understand the health dimensions of our work, what tools healthcare might have to support these families. And if in the end, we're really serving the same clients/patients, can we do it better together. And so doctors have come with me to court to testify. They have written affidavits in support of our advocacy. They have provided us with records and lots of other expertise that has supported our work. And that, I think, is often when the model is at its best.
Great. So a couple more questions in the Q&A box. Many rural areas are underserved both medically and legally and have little, if any, access to urban academic centers with greater availability of resources. Do you have any suggestions as to how a medical legal partnership in a rural area might look?
Oh, this is such a great question. So there has been a huge focus on these sort of gaps in rural areas, both on the access to justice side and on the access to healthcare side. And one thing that has been really interesting during the pandemic is to see how telehealth and sort of the remote provision of healthcare services has played out, and then also how sort of the remote provision of legal services and access to justice has played out. And maybe one silver lining for some people, and sort of acknowledging that there are great digital divides in our country, and some people don't have access, to a computer or to broadband, or like getting on Zoom and a telehealth call is not that easy. But many people have learned how to use those tools. And so, for example, the medical providers that we work with found that there were many families that actually it was much easier for them to access their healthcare through telehealth than had been, before the pandemic, when they were required to come in for certain visits. And I think that is a model that we are seeing kind of growing in rural areas. And, through the pandemic, we have a former colleague who is a senior attorney for Iowa Legal Aid, and for many years in her practice has been remote lawyering and bringing kind of access to justice throughout the state, from her telephone and increasingly from her computer. And she came and talked to our students about how to best lawyer, because there really are kind of best practices for how to work remotely. Of course, it's not a substitute for the need for greater access to bricks and mortar healthcare and to in-person lawyering, and somebody who can like walk into the courtroom with you and be by your side to prepare for that. And so there are a lot of great efforts underway to sort of incentivize people in the legal profession and the medical profession. I know I used to teach at University of New Mexico, and there's an opportunity for medical students to come to medical school for free in New Mexico if they commit to serving underserved rural areas after they complete medical school. And those types of models, I think, are really important to try to kind of build out this work in areas that are underserved across both of our professions.
Great. So another couple of questions. In your experience, what are some of the most effective ways to share knowledge and best practices with current legal and policy leaders to affect change?
That's a very good question. Sharing best practices. Well, having opportunities to be in dialogue like today are really, really important. So thank you, Ren, to you and to your classmates on the law review for facilitating these types of conversations. And I was especially struck when you started out by saying, we have people from Washington, D.C. and Texas and listing all these places across the country, because we do need to come together and learn from each other, and get out of our own silos. And that's geographically, that's professionally, and those kind of cross-disciplinary conversations, I think, add a lot to the sharing of best practices. And, I've had calls where I've talked about some of these issues where a administrator of a health system who has a lot of power and sort of shapes the way that healthcare plays out is like on the call, and all of a sudden, might be thinking about things differently. And I have certainly learned from people that way. I also think something I mentioned earlier is really important, which is, when we talk about best practices, like we normally think of, what the professionals have studied and the evidence base and what the research shows. And that's really, really important. But I think it's also really, really important to know that the people who are most affected by these health inequities have their own lens on what's best. And their voice needs to be elevated in these conversations. And there have been calls, within kind of the health justice framework for, all kinds of different ways to connect policymakers, for example, with the communities. So, having leading national organizations invest money in actually supporting community organizations, bringing focus groups together, bringing people together, creating when executive branch agencies, for example, create like community boards and task forces to inform their work that is really not just made up of professionals, but made up of community members, and we as lawyers can support, grassroots coalitions and community members in organizing in ways that allow their voices to be elevated so that their ideas for what health justice should look like are actually brought before policymakers. So for example, in a number of places across the country, lawyers are supporting tenants in organizing into tenant unions so that they have sort of a collective power, and lawyers are helping them to figure out how to do that and giving them the tools to actually bring their voices and really important views before policymakers. So thank you for that excellent question.
Great. So one more from the Q&A box. As we're talking here about the medical models of health, how does the integration of public health practitioners, like health educators, epidemiologists, health policy specialists, that kind of thing, play into your work? This attendee has said that this is especially important as these individuals are trained in social determinants of health and other areas of planning and implementation of health programs. So how are these partnerships being explored?
Such a great question. And I think increasingly we're seeing sort of public health advocates and professionals and researchers being built into medical legal partnerships, for example. And I think that is really important. And I think that part of this work, it gives us a window into doing research, into really understanding by professionals who are highly trained in research and epidemiology, to really understand, what impact we are having, what impact we could be having, what are the needs on the ground, how does that sort of map on to the public health sphere. And so, for example, on our team, we have a research collaborator who has a PhD in public health from Johns Hopkins, and she's directly integrated into our team, both to teach us about some of the things that the person who wrote that great question was getting at, and also to help us kind of do our work better around our research and around what lessons we can take from the work that we do. But all the way into the doctor's office, the sort of role of public health is really important. And so health navigators and health educators, community health workers are really, really important players in health justice. They can also be trained in understanding law so that they can connect people with resources. There's a program across the country called Health Leads that actually sort of deploys college students in kind of this community educator and community health worker role, and it helps gives them the tools to connect people with different resources, including legal resources. And then those community health workers can train us as lawyers because they have such incredible background in what it means to work with patients right in the healthcare setting, to meet people at very difficult times in their life and support them. And they have access to all kinds of resources, that help us, that can help us support our patients with even more tools in their toolbox. And then I think the last thing I'll say is that public health professionals clearly have been really, really important during the pandemic, and sort of the messaging that goes out from those who are sort of public health policymakers, those at the CDC, those who are in public health agencies in our states and local communities, is really, really important for thinking about how we get people access to resources. So, for example, it's been really interesting to me to see how the COVID task force out of the White House has not only been looking at sort of kind of classic public health information and communication around the pandemic, but also has been keeping in mind the eviction crisis and the prevention of evictions as part of its COVID response. And so when I've been on those meetings with the White House, it's been interesting to see the public health professionals right there, in this conversation that is so embedded in the legal work that we do, and kind of seeing those connections, talking about them in a way that actually has influence on state and local policy, and sort of aiming to think really broadly about what public health should look like in a way that engages other sectors like housing.
Great. So I think that's our last question for right now. Yael, thank you so much for this presentation. Everyone, Yael's accompanying article, Lawyering for Health Justice, is forthcoming in the University of Richmond Law Review Symposium issue, which is to be published next month. We're going to take a quick break, and then we're going to move on to the next panel with Jessica Roberts and Dr. Chris Ghaemmaghami on trustworthy digital contact tracing. Thank you so much.
Thank you, Ren, and thanks everyone. Have a great day at the symposium.